this question. This was the question during last TBL. And for this question, out of you, 97 of you were able to correct the answer. And 125 were deceived. You are unable to correct this answer. Well, to learn these questions, to understand these questions, it's very important understand the mechanism. Understand what is happening. If you understand what is happening, then answers are not far away. If you see someone, a male or a female, the foot condition like this, lateral rotation, you should have only one answer in your mind. Now anybody sitting here, can you tell me why this is laterally rotated? Yes. If you put the right words, I have no problem with your answer. But this answer will not give you full marks. That's what I'm emphasizing on. This is femur. It has an attachment which fixes it with the head, with the acetabulum. So it was fixed in one place and it was moving according to that fixing. Now because it's broken, now this femur is free. It rotates in its vertical axis, in its longitudinal axis. Now femur can rotate like that. I know to my lesser trochanter there is an attachment of iliopsoas. Don't use psoas, okay? You are using with a little bit like that. So iliopsoas. Now they are pulling it. On the other hand, I have gluteus medius and minimus. So both of them are trying to pull it. Once it is free. Before femur was fixed in a place. Now femur is free. So Osama, what you are trying to say, axis? Yes, axis is there. But before it was attached. So it cannot move like this. Now it can move like this. So with this action and the minimus and medius action, it opens up laterally. So the right words are, in the neck of the femur fracture, the shaft is free to rotate about its own axis. Before it was not doing that. And the psoas and iliacus produce the lateral rotation of the limb. That is the characteristic feature of a fractured femoral neck. If femoral neck is fractured, it has to be rotated. It is a fix. It has to be rotated externally, laterally. If the other options were all about dislocations, dislocation will give you the shortening, but will not give you the lateral rotation. Because femur is still having a head which can stuck somewhere. But now with the fracture neck, femur is a vertical long rod. It can move on its axis in any ways. There is no one who stops it. Are you with me? So shortening is because of muscle spasm. Now with this going further, I have bring some more examples where I should be try to clear your more concepts. And here you are looking at the situations: a proximal femoral shaft fracture, a mid shaft fracture, and a distal shaft fracture. So there are free fracture location. So let's take the example of option A. So option A, fracture of the proximal shaft. The proximal fragment is flexed by iliacus and psoas and abducted by gluteus medius and minimus. So this is happening when you have fractured the proximal part of the shaft. When you fracture the middle part, what is happening? Fracture of the mid shaft, flexion of the proximal fragment by iliacus and psoas. And can you see these bones are overriding? The pull of adductors, this bone is now free. So they can pull it easily. And this is being lifted by these muscles. The flexion of the iliacus and psoas major, they are flexing it, they are pulling it upwards. There are the medius and minimus, so they are bringing this fragment upwards. These muscles, now this is disengaged from here. Now this spasm of the adductors, it further pull it upwards, so your limb becomes short. Are you getting it? Now with the distal fracture, which is more like a supracondylar fracture of the humerus. Remember, supracondylar fracture of the humerus, don't try to bring radial nerve and ulnar nerve. If I want to put a question on radial nerve and ulnar nerve, I will use the fracture of lateral condyle or medial condyle. Got it? Because these nerves are related to those condyles. They are not related to the mid shaft, to the distal shaft part. So, if there is a supracondylar fracture, word is used, or you are seeing at a fracture occurring in the distal part of the shaft, definitely I'm talking humerus, there is only two structures. One is brachial artery, one is median nerve. Brachial artery is gone, you are getting weak pulse or no pulse. Hand becomes pale. That means artery. loss of function of muscles, loss of sensations on the median nerve area supply explains me that there is an injury occurring to the median nerve. It is quite possible injury to the brachial artery and injury to the median nerve is both are being affected. So you have to come to the conclusion this is an injury to an artery, this is an injury to a nerve, or this injury involves both of the structures. Are you clear? So these concepts should be very clear. Now in case of this lower femur, what happened? Why this head is, the lower condyles of the femur are tilted downwards like this? Why these sharp edges are denting over the popliteal artery? Because gastrocnemius muscle is attached here. Gastrocnemius, it is free fragment. Gastrocnemius is pulling it forward, and due to this pull, this sharp edge, this jagged edge is really causing dent, is really causing an penetration, is really causing a pressure over to my artery, which is just lying just close to that, and that artery is nothing but the popliteal artery. Is that clear? So these concepts should be very clear. So again, the mechanisms are important to understand the things. Is it clear? Now going further. So third segment I've talked about. And now all these fractures, overriding of the bone ends is produced by the muscle spasm. No matter it breaks here, it breaks here, it breaks here, or it breaks at the neck. This overriding of the bone is occurring. This shortening of the limb is occurring. This explains the overriding, but in the neck fracture, that explains the shortening of the limb and lateral rotation is all because of the spasm of the muscle. When there is a fracture, their muscle goes in spasm due to trauma, and that spasm causes contraction, and that contraction brings the things upwards or wheresoever you have freedom of the movement. Yes?
Is this the spiral fracture? Is this the one they call the spiral fracture?
My dear, the word spiral fracture is a fracture which goes vertically or obliquely downwards. Not straight, but like this. A fracture which goes like that. If we go for classification of fracture, I don't think you need to know right now. Just reach to year 3 or 4. There you will be learning it, different type of fractures. Right now you're looking at a classic transverse type of fracture in all these cases. Is this clear? Any question? Now, what is happening? Yeah, we all know soccer. American football. They are attacking, but I'm not concerned with attacking. I'm concerned with... Jan is grabbing him. We all see that. So, okay, make my life easy. Who is at risk? Number 3, number 28, or the one who's in here? 28. What about him? You know, he has to land. He's already landed. He is somewhere. He can, he cannot. And he definitely will. Now see what happens. Unable to stand.
Isn't that the blue team 28?
But he's not 28. Now what's wrong here? Foot got stuck. Now see the situation here. Now what is happening? 53. Sabr. Abdul Majid will come to that. Now what happens? So to understand all this, we need to talk about knee joint today. Why we need to talk about knee joint? Because we can see that a big number of sportsmen during their sports activity sustain these injuries. So before starting, what type of joint is this? Synovial hinge modified. These 3 words I have heard. Synovial is right, but simply saying synovial is not the answer. It's a modified hinge. Why is a modified hinge? Like, listen, if you answer one by one, then those who don't know, they will get the answer. But if you make a fish market, then those poor who don't know, they will never learn it. And my objective is everybody who leave this room should go with some extra knowledge. I can see who's raising hands. Tariq, start.
It's a low degree of rotation in a flex position.
So you mean to say it's not a uniaxial type of joint, it's a biaxial. That's why if we call it a hinge type of joint is usually associated with uniaxial type of movements. But over this joint, we had biaxial type of movement. And why this biaxial movement is needed here? Muhammad.
Why is it needed?
Yeah.
For free movement. So the movement.
So then you need, then why you have multi-axial here? There's a free movement. There is no free movement more than shoulder and more than wrist. These are the free, they are multi-axial, so they are not biaxial. So free movement, if it was your formula, then we don't. This is not biaxial. This is multi-axial. This is multi-axial. Uday. To lock and unlock. Give a big hand to Uday. So to bring locking and unlocking. What is this locking and unlocking? Who will explain to me? No, I like to involve everybody. Let's see my friends who are working. He's working very hard, my dear. You, I don't know your name yet. Rafe. What is this locking and unlocking? Abdul Majid. When you walk, you dance also? When you gate. Really? I'm coming. I don't know your name yet. Rakan, yes, Rakan. So why we need locking? You're not giving me the answer. Omar. Mohsen. Radwan. Ahsan. Safwan. Najmuddin.
I think when you lock the knee, you're able to stand and keep the...
Yes. If you can say we need locking in the elbow, but we are using more muscles. So when I am standing, my whole body weight is there. So to lock it, I want my muscle to be relaxed and free. So after locking, my muscles who are maintaining this position, they are at rest. Because we are standing most of the time. During our work, we are standing most of the time. So we cannot use those muscles for longer period. Otherwise, and if we could have been walking by our hands, then we could have need a locking mechanism here. Can anybody tell me in a shortest word span how this locking is happening? Yes, my dear. Yes. Yes, Nizami. How? I want mechanism. Sinan. Muhammad.
That when the condyles are attached or like completely resting on the tibia, then it will be locked.
Guys, you get it? What he's saying?
No.
They are not agree with you.
They didn't understand.
No, so you have to. Your job is to make them understand.
Yes. So in the standing position, when the knee is extended, the condyles will be will be resting on the tibia completely.
No.
So
You have to make them understand. And then you are not giving them the mechanism. You are telling them this is what is outcome. You have to tell them why this is happening. Okay. Tariq.
It's the mechanism is related to
Perfect. So what is that? Mohammed, listen to it now. This is what you have to answer.
So the lateral condyle of the femur, the anterior aspect, it's roughened. So compared to the medial condyle, which is allow more movement. So when I'm extending my knee, the medial condyle of the tibia will be, the lateral condyle of the tibia will be stuck in line. It's because of this roughened area. About the medial condyle of the tibia will have a free aspect of movement compared to the lateral, allowing the medial.
Guys, you got what Tariq was explaining? Talal, you get something out of it? If you get, say yes. If you don't get, say no. Because my message is when everybody leaves this room should be knowing it. Because I'm going to ask it. Saeed. Because let me explain it. What Tariq was saying, his answer is very close to the right answer. Only he need to bring 2-3 right words, then he deserve a clap. but right now no. Yes, Said.
When our knee is extended, the shape of condyles are oval, but when it's flexed,
No, you missed the boat. My dear, is not the story of ligaments, it's the story of condyles. Let me stay with the condyles.
I think for the knee, the femur and for the joint, it's like this. So when you
It's like this. You will put this picture, the video in. So you have to explain it. Osama, can you enlighten it? No. Uday.
So during the last period of expansion, the medial condyle has more articulating surface than the lateral condyle. Therefore, in the last 15 to 20 degree, the femur has to rotate medially to offer more articulating surface for the lateral.
Give a big hand to this. So if you see the medial condyle, the articulating surface is longer. If you see the lateral condyle, the articulating surface is shorter. So to meet the full articulation over the medial condyle, what happens? The knee goes in hyperextension. One is extension, one is hyperextension, because more movement is required. So medially, I will demonstrate this in the evening lab on the dry bones, exactly what happens. And then this more articulation, it makes a little bit medial rotation of the femur above the tibia, because the articulation process has to complete. Medial condyle is bigger, has more articulating surface. So to meet that, there is a little bit rotation. Along with extension, there is a rotation. This rotation is bringing the locking mechanism. Got it? Clear? So medial rotation, hyperextension at the knee is bringing us, it's associated with the medial rotation, and that locks the knee. Now question is not done yet. Who unlocks the knee? Let me try other ones. The guy with the red cap. I don't know your name, my dear. Nawaf. What do you think, Nawaf? So what muscles? Flexors. No, my dear, it's not helping this way. Yes, my friend. With the blue cap. Yeah. Same thing. Popliteus muscle. Give a big hand to him. So now, when I want to flex my knee, I need the help of, I'm depending on popliteus. Popliteus acts like a key, muftah. If popliteus is not functioning, I cannot unlock the knee. So popliteus reverted. There is a lateral rotation occurring. First there is a lateral rotation. Then there is a flexion. If you don't bring that lateral rotation, it will never flex. If you damage the popliteus, you cannot unlock the knee. You can break the knee now. So you have to bring it back. Bring it back to the neutral. If you are using a car with a stick, first you have to go to the neutral. You cannot put after first the fourth gear. You have to go to the process. But you are using automatic transmission, you don't understand the mechanism, what's going on. But if you are using a stick, if you are really enjoy the racing and all that, then you need a stick car. The car with a stick. So a stick, everything has to go to the neutral, and then you go to your desired situation. So the same is happening. So you put it medially locked. For unlocking, you need someone who has to bring it back. Align it, and then you can bring flexion. I hope this locking and unlocking has been explained. Anybody who is not able to understand yet, please feel free to ask. I'm ready to do it again. Yes, what, Ridwan? You are coming tomorrow for the lab. I will demonstrate there. I think talking in air. If you want me to teach you how to swim, if I start teaching in this classroom, probably it's not the best option. The best option is I'll kick you in the water, in the pool. When you swim, you can swallow a little bit in your mouth and nose. Then you will learn all the steps. So remind me in the lab. Anybody, remind me in the lab, and I will put inshallah one station where somebody will be standing there to be explaining to you what is locking and unlocking and how it is occurring. For that I need real human bones. I don't need plastic bones. Plastic bones have, little aesthetic issues. But real bones are showing you the real features, and we have them. So you will be seeing it happening, and if it's not clear, I will be there. Come and ask me. Yes, Abdul Majid. My dear, think, if you don't have popliteus, if you cannot bend your knee at all, what will happen? Think how vital it is. You tell me, is it vital or not?
Very vital.
Is the main contributor. Got it? Everybody settled with this concept? Clear? Can we go with the ball rolling? So we all agree that knee joint is a modified hinge biaxial type of joint, not uniaxial. And why we need a biaxial? Now the question comes, why we need movement? We need a movement to lock it and we need a movement to unlock it. Otherwise, we are doing primarily flexion and extension at the knee joint. Is that clear?
For weight bearing and for relaxation of our muscles.
Exactly. But the prime function is flexion and extension. Clear? So let's start the ball rolling. You're looking at a knee joint from the front. You're looking at the knee joint from the back. You know about these bones. Somebody has already explained these bones and these bony features in the lab. Did somebody? I think there was one station. Osama did. No, Osama did. Last week somebody did. Yeah, Osama did. So now let's label it. We know these bones. I will not go in these detailing. We know these are the condyles of the femur. And these are the condyles. These are the epicondyles 3 and 4. And now I have the condyles for the tibia. Now the space between the condyles, I named it. What name should be given? Guess.
Popliteal.
La. So between 5 and 6, this space is given the name tibial plateau. Between 5 and 6, this area is called tibial plateau. It's a name. I have no control. I didn't name it. Now, what are these two small mountains? Eminence. Eminence in the tibia or spines of the tibia. Intercondylar eminence or tibial spines. Clear? Any concerns so far? Good. Now let's start bringing the ligaments. The first ligament is a capsule. Fibrous capsule. This capsule is unique. This capsule is different. It's not like other capsule of the body. I will explain it shortly. But now I put 2 ligaments. Is really 2 ligaments? We know about more because I know yesterday you took a class with Sheba and he was explaining a little bit more. Was he?
Yeah, we have 4.
So he was talking 4, but actually not 4, is more than 4. There are so many. So why I put 2? Anyway, let's see. Then I put a word here, cruciate. Cruciate means crossing. And I put word collaterals. Collateral means they are going parallel. Then I put a word cartilages. So I have 3 broad categories. After this I have 4, 5 more cartilages. But I am emphasizing here the major issues, not the minor and small sidetrack things. So now I am showing you 3 main, but why I am putting 2? Yes, there are 2 in each category. So I have 2 ligaments for cruciate, 2 ligaments for collateral, and 2 ligaments for cartilage. The word cartilage, the word ligament, the word tendon, they are overlapping. And we are using, when we use in term of a joint, our philosophy is a bit wide. When we are using under microscope, cartilage is different, tendon is different. Okay? So try to anticipate these gaps. So my cruciate category, a tendon who starts from the superior surface of the tibia and it's going backward to the lateral condyle of the femur to its medial wall. This is the medial wall, this is the lateral wall. So from the anterior aspect, superior surface of the tibia going backward to the medial wall of the lateral condyle. This is my, is it anterior? We call it anterior cruciate ligament. You are looking from the behind. Same is happening. Coming from the front, coming backwards to the medial wall of the lateral condyle. Remember this word, medial wall of lateral condyle. For last 2 years, people are writing a note to me all the time. You are saying this and book says different. Book says lateral condyle and you are saying medial wall. I am saying medial wall of the lateral condyle. Got it? So this is my anterior, so I call it anterior cruciate ligament. It's famous with the name of ACL. It's a very commonly injured ligament. Who are affectees? Basketball players, baseball players, any game, any football, any type of football, no matter American football or other football, soccer or whatsoever, where you have a twist occurring around the knee, there you have ACL injury. Simply remember this way. Any twist over your knee, you're going to have ACL. I saw yesterday, year 2 boy, he came to me, his name is Saleh, and he was holding a crutch, and he came with a typical ACL injury. If you want to know the details, go and talk to him. He will tell you he's a right immediate victim of this ACL. ACL is a very commonly occurring injury in these sports, and it's a very nicely repairable, so no big deal. I can see all the big names have ACL damage. Most of them. Now there is another ligament which starts its journey from the upper part, posterior surface of the tibia, and is going forward towards the lateral wall of the medial condyle. So it's going opposite. They crosses each other. So same is happening coming from the back to the front. So that is coming. That is my posterior cruciate ligament. I call it ACL and I call it PCL. Is this clear? They cross each other. Now I have a ligament, collateral ligament. Now Muhammad, I have a problem with this collateral ligament. Because if I say collateral ligament injury, I might be confused. I have collateral ligament in the elbow. I have collateral ligament in the wrist. I have collateral ligament in my wrist, in my digits. I have collateral ligament in my knee. I have collateral ligament in my ankle. So I have collateral everywhere. So I have to be specific. Medial collateral, medial side I have this big bone, the tibia. So I like to call it tibial collateral ligament. Is that fine? Tibial collateral. And one is the lateral collateral which is going to the fibula. I like to call it fibular collateral. Make sense?
Yes.
So now I'm more specific. Otherwise, if I say medial collateral, I don't know. You're talking elbow, you're talking knee, you're talking wrist, you're talking ankle. Right? So we have these two collateral ligaments. So are there two? Are there two? Now cartilages. I'm bringing one. From this medial, we call this meniscus. And then we have lateral meniscus. These menisci are thick pads, cushions, shock absorbers. Then you can ask me, before you are telling us bursas. Bursas are for shock. But why we need cartilages here? Because there is too much pressure, whole body weight. If I put a bursa could have ruptured. It could have damage. It cannot give me what I need. Got it? So there is been provided a thick pad of cartilage, which is shock absorbing, which is accommodative, which helps in so many ways. And those who are using this menisci a lot, who are the one who are jumping, their job is to jump. Who are those people? Basketball players, baseball players, cheerleaders. How many times they are doing more things than the knees. They are doing it, but they are jumping less, doing a little bit more. We'll learn it next year when we'll be talking endorepro. So they are not there to show you their jumpings. Yeah, this is why you see cheerleaders.
It's like jumping. I swear it's a jump.
Khalas, no problem. So the jumping job is more confined for baseball players. For those who are jumping, making long jumps. For those who are pitching the balls. Those who are playing football, they are jumping more. So if you are, a pitcher, when he comes and throw his ball, you always have to jump over his knees. So each jump, and in one day, how many times when he is playing a league? Every day, so many matches. So jumping and jumping and jumping. We are not jumping that much. So every time jumping will cause damages to these menisci. Got it? So these menisci get ruptured. They get destroyed. But with the normal people, less likely. Only happening when we have some twisting sort of things. Some severe twist occurs. Tell me how frequent someone is twisting your knee. Not at all.
Rare.
Very rare. Unless you are been caught by a wrestler and he moves your, he start twisting your leg. Otherwise it's not happening. No matter what you fight. Nobody's twisting your knee. So those who are indulged in the sports activities, they are more prone to these sort of things. So let's establish all that. So I have these menisci. Now there I bring someone on the lateral side. This red oval thing. Huh? No, it's not bursa, my dear Muhammad. This is on lateral side and this is my popliteus tendon. So popliteus tendon is under a ligament. Before we learned so far, everything was outside the capsule. Everything was outside the cartilages. But here now, with the knee joint, there are exceptions. We'll be using more terms. Intra-articular, intrasynovial, intracapsular, extracapsular, extrasynovial, intrasynovial. So many things are there. So many terminologies are here. So this is only on the lateral side. Medial side, my tibial collateral ligament and my medial meniscus, they are blended with each other. They are fused with each other. They are one. Here they are separate. And even I need a bursa between this tendon and between this ligament. Because there is a movement, there is an unlocking occurring all the time. So I need to put a bursa here. Shortly I'll be bringing that. Is this clear so far? Now going further. Now we are looking at the same thing from the lateral perspective. We know this is quadricep tendon. It passes over the patella. Then we change its name. We call it patellar ligament or patellar tendon. What is this thing which is showing up?
Meniscus.
No. Eminence. Intercondylar eminence. We saw it.
So this is the book.
Now there's my anterior cruciate. From the anterior aspect, going backwards on the medial wall of the lateral condyle. Now, tell me one thing. I'll talk about that. Anterior cruciate, you all agree? Yes. To the medial wall of the intercondylar fossa posteriorly. Posterior cruciate from the back to the front. To the posterior aspect of intercondylar eminence. All clear? So this is about detailing. But what we need is this. You need to be good at it. What are the functions of these ligaments? Precisely each and every ligament and what is their function.
The anterior cruciate ligament prevents hyperextension and the posterior cruciate ligament prevents hyperflexion.
How?
Extraflexion.
How?
Once we extend our knee joint, the anterior cruciate ligament will be stretched and the overextension of this joint will not be occurring because the ligament is stretched already.
Do you think you are saying right, but do you think it's easy to remember?
It's the opposite.
No, do you think it's easy to remember? Let's not, no, you are saying right. Now we need to design something which is easy to digest, which is easy to palate. He's saying right, perfect, no problem with that. But we need some shortcut. We need some easy learning. Are we? You can memorize it, but you can forget it. At one time you are not sure what I've said. So let's go for some more logic. Can we try?
Yeah.
Sure. So now I said, I bring one term here. I'm saying my posterior cruciate ligament is more stronger. Why? Can you justify this, Muhammad? Why I'm saying this?
Justify?
Why it's more stronger?
Because we flex the knee a lot, so we need to prevent.
But you are saying before, the flexion, if it prevents the hyperflexion.
Yes.
So it's more stronger, and then extends it. Then ACL is hyperextending as well. So why it is more stronger than anterior cruciate? Why posterior cruciate ligament is more stronger than anterior cruciate?
Because it's more involved in the injury.
Why? What makes him weak?
Because of the lateral rotation, it prevents.
It has to do nothing in lateral rotation.
The whole body weight is here on it and standing back.
Yeah, he's making sense. He's getting close to the answer. Yes.
The angle of the flexion is too high, but for the hyperextension it's only a bit because the lock, the knee will lock. So you don't need a very strong ligament.
Think a little bit more. Osama.
Because the posterior cruciate ligament is facing the quadriceps tendon.
So, and that one is coming from the quadriceps tendon. There's no big, both of them neutralizing each other.
No, it is the only one posterior artery.
Correct.
Which question is why it's important?
Why is more stronger?
The reason why it's more strong?
God knows.
No, we have a reason. We have a reason. Sabr. God has taught us so many things. Alhamdulillah. So many things we don't know. He knows ultimate. But He taught us so many things. Huh.
It prevents the posterior displacement of the tibia, which might compromise the oblique fossa structure.
No. So let's see it. Now, answer my one question. Most of the injuries occurring when your knee is extended or flexed? Flexed? When you're playing sports, your knees are flexed or extended? Extended. So in extension, who's there for during extension? Anterior cruciate. So more stress is the one who is related to the extension. The posterior interosseous is more related in the flex. So if we are playing a game which is being done in the flex form of the knee, tell me a game when your knees are flexed and you can play that. Video games. Yeah, very right. Chess. So do you need some energy? Do you evolve some forces? You are playing your Xbox. You are enjoying your Nintendo and this all that thing. You are enjoying your games, but you are not in an active form. So active form is when your knees are extended. So knee extended. Very rightly he mentioned that in extension, to prevent hyperextension, the muscle who's at stretch, the tendon who's at stretch is my anterior cruciate. So in extended form, most of the games have been played. But in flex form, none of the game has been played. The physical game I'm talking. You cannot really flex your knee and start playing something. You cannot fly with this. Right? So that's why. And then why this thing is more stronger? Because flex format is not used. Extended format is used. Got it? Clear? So God taught us. Alhamdulillah. So now going back, answering, giving you more detail, more insight of this concept. Guys, this lecture is all about concepts. It's not like memorization. So there is the axis. Axis for what? So I'll talk here about posterior cruciate. Posterior cruciate, and this is what? Flexion. Closing the knee. Flexion. So there is, in the flexion, there is a maximum stretch occurring at my posterior cruciate. Got it? It prevents superflexion. The forces are like this. And this is my anterior cruciate. It's opposite, extension. Hyperextension, there is more stress over this. Got it? Now concepts are clear? We cannot, if you try to extend it more, it can be broke. You try to flex it more, it can break. You try to extend it more, it can break. I have a small video which will be clearing some of your concepts. Shortly I'll be sharing with you guys. Clear with this concept? All clear? Everybody's on the board? Thank you. Now, dashboard injury. Dashboard injury is a very popular injury.
Yes.
And now, tell me about first, what is Saddam injury? Saddam injury. So we call it in English, it's the bumper injury, but I heard today that Saddam is, only I know there was one Saddam who was killed, but now I know. So this bumper injury is, if you are hit by, if you hit by a sedan, your tibia will be broken. But if you are hit by an SUV, your abdomen will be ruptured, because SUV is high. So injury from a bumper, from a Saddam, if it's a car, it will be damaging your tibia. So now dashboard injury, you are sitting in the car. You are sitting in the car. So how you are sitting?
Anteriorly, is moved anteriorly.
So I'm sitting, I'm doing it for you. You are sitting and you are driving it. You got stuck here. You may damage, you may be hit onto your femur, or you may be hit onto your tibia. It depends on what part is coming to you. Am I right?
Yes.
So if it hits on your lower end of the femur, and if your legs are like this, you will have posterior dislocation of the hip. And if you are driving your car like this, your one foot is on the window, other foot is somewhere here, then what will happen? You have the impact of injury, your acetabulum got fractured, your hip get dislocated. and your sciatic is gone. So please don't do it. I have seen some very stylish guys, they are riding their cars like one leg is on this window, another leg is I don't know where, with the back mirror. So be ready, if that happens, you're going to lose your acetabulum. Along with, because there is an angulation now, and before it was like this, so it can slip out. So if injury was occurring to the lower end of the femur, you're going to have dislocation. That is also a dashboard injury. But what is more particular, if you hit here, if you hit at the tibia. So let's see what happens. So we'll talk about PCL here. We'll talk, now there's a force, see? And this force, what it causes? It causes too much posterior displacement of tibia. So now, what has happened? There was an injury, there was an impact here. Due to this impact, this tibia moved backwards. This tibia moved backwards. This was super extended. This was super stretched. Let's say it came here. How much stretch is possible? If it reach here, this is going to be damage. So in a dashboard injury, if it occurring to the upper end of the tibia, you damage this tendon here and you damage this PCL here. Yes?
Will there be any fractures in the tibia itself?
It will fracture, it may fracture the tibia, but it will also, because tibia has been pushed so much backward, there will be maximum stretch on PCL. PCL has a limit to go backward. PCL has a certain limit. If you push more, what will happen? If you are standing behind a door and a big Superman comes and he bangs the door, where you'll be flying in air. But if a Superman is standing and you are pushing it, he can control you with your finger. So that is happening. Is this clear?
Yes.
So that is the concept which you need to understand what happens in a dashboard type of injury. Is this clear, Rafi? Abdul Majid is still... My dear, that is all the consequences are. But first I need to teach you here, after this will happen. You understand with this? Are you clear with this? Any issue? Khalas? Nihai? Good. Now going further. Are we good till this point? Alhamdulillah. So now we have a rupture of the posterior cruciate ligament. And then this, the red boxes and blue boxes are worth reading. Now this is a little bit memorization. Who's bringing what? Flexion is brought by this group of muscle. Extension is brought by these muscles. Medial rotation at the knee of the flexed leg is brought by these, and lateral rotation by these. So this is all about memory. So I was talking about, so like whatsoever we have learned so far. So we were trying to recap what we learned so far. Still there is any question? So primarily these two ligaments, the anterior and posterior cruciate ligaments, are the main ligaments which are used to their maximum during the rotational movements. I'm using the word main ligaments. They have assistance from these collateral ones, and menisci has a separate role. Now let's start building the collateral ones. We know about these features. So now why we need to do this? That's my question. Why we need to tap over the patella or the patellar ligament? Why we need to do that?
To see the reflex of the rectus femoris.
Why? Why? When you need to check the integrity. So if you are suspecting someone has affected by a stroke, someone has affected by some spinal cord injury, and you want to evaluate, or you are in a rehab process, you started some rehabilitation with someone, now you want to see how much success you have achieved. So you want to check the segments of the spinal cord. If you tap on this tendon and you look at, don't think what has been shown in the cartoons, so doctor is hitting here and the patient is hitting the doctor, that's not happening. If you do that, if you think that is happening, that's wrong. So when you hit here, you should look for these quadriceps. So you should expose the thigh of the patient. And you look, is there any movement occurring? It's a very faint type of movement. Is it occurring within the quadriceps? It means there is some energy. There is some power. So more the power, more the impact, better the recovery.
So it should be flexed. The knee should
No. If someone is able to flex the knee, It's not flex and extend the knee. It means there is no problem with the thing. That you don't need this test to be done. You are not evaluating a spinal nerve. You are evaluating L2, 3 and 4 segment of the spinal cord. Because we know that L2, 3 and 4 is the mother place for my femoral nerve and also my obturator nerve. There's the difference is what? Only the femoral nerve anterior division of L2, 3, 4, ventral rami. And obturator L2, 3, 4, the posterior division of the ventral rami. Like you remember the ventral rami and dorsal rami for brachial plexus. They all are coming from ventral rami, anterior division and posterior division. So we are checking, we are evaluating. The nerve has not become that strong. The spinal cord has not become that strong that the femoral nerve or obturator nerve start functioning. So you are just evaluating. If you are suspecting someone has a stroke or a stroke in evolution or someone is recovering from a stroke, so we need to check these reflexes and our target is L2, 3 and 4. Is this clear? So now going further, we know about this ligament. Who is this? Tibial collateral ligament. And we have, so now this is important, tibial collateral ligament or medial collateral ligament is closely blended with the medial meniscus. If 3% tie them each other, they stand by tying up each other. So if you are able to push one, all of them will fall. If someone is standing and you push him, only he can fall, but others will not be affected. The same goes, so this tibial collateral ligament is blended closely with the capsule of the joint and is blended closely with the medial meniscus. So if there is an injury occurring to this, it bound to get involved the medial meniscus as well.
Unhappy trial.
Sabr. Unhappy and happy will come later. And then if it is occurring on the lateral side, the situation is different. So this is a worth remembering point. Now, we are looking from the lateral side. We have the popliteus tendon. I told you before, it is going through this. So we need to minimize friction here. So we need to bring a bursa. So that minimizes the friction here. Right? So this is the function of the fibular collateral ligament. Now going further, we are looking from the front. We know these bony landmarks. We know about these ligaments. And we know about this is the quadriceps tendon and is reinforced by vastus intermedius, lateralis and medialis and rectus femoris. They all make the quadriceps tendon. Now, you remember in the beginning I said the capsule of the knee joint is unique, is different. It's not complete anteriorly. It is well developed laterally, it is well developed posteriorly, but anteriorly we don't see the capsule. So how? Then what happened? That synovial fluid might leak out. There is no capsule. So how it is happening? Who is preventing it? Mohammed, can you highlight it a little bit?
The synovial membrane.
Synovial membrane, if it's exposed, it's prone to damage. So how this is being prevented? What is the mechanism? How this synovial fluid is retained and synovial membrane is retained in its place? Because we don't have established capsule anteriorly. We have established capsule posteriorly. We have established capsule laterally.
I don't like to say something I don't.
You don't know. Okay. Anybody knows it? So, but I can see there's a gap. There's a patellar tendon. And where is the quadriceps tendon? The joint is here, my dear. Patellar tendon runs here. Let me complete it for you. Now there is a quadriceps tendon and patellar tendon. So this is open anteriorly. Anything can enter. Yes, Tariq. What make it close? How I can close this space?
Patellar retinaculum.
Patellar retinaculum. What's that? Can somebody will highlight?
Upper aortic expansion of the vastus medialis.
Very good. Give a big hand to him. So what happens? From this we had an expansion. We had something which is projecting. And that's something which is projecting. And there is my iliotibial tract. So this one is the lateral patellar retinaculum. And this is my medial patellar retinaculum. So these are the expansion. These are the some fascias which are emerging from these vasti. So these are some expansions. These are some sheets These are some curtain-like thing.
From the femoral fascia?
No, from this, they are the thickening, they are the modification in the fascia of the thigh, deep fascia of the thigh.
So the deep
That
fascia
so deep fascia between this vastus and these ligaments, that becomes more stronger, that become more reinforced. So it's been replacing the concept of the capsule anteriorly. So anteriorly we don't see any capsule. These two, see, before, so they were open before. There was no capsule visible here. So these two reticuli, they are the one who are closing this space and they are stabilizing it. Now, what is happening further? So now the fibrous joint capsule, we talk about it. What is happening to that? Now, what I'm doing, I'm showing you the joint capsule visible from laterally. Bursa is there. What are these two stars? Any idea, Tariq? Why I put these stars here? Intramuscular injection.
No, it's never.
Maybe you use them to make it between that they got it stabilized.
Any other idea?
Surface anatomy.
Anybody else? Nobody is answering from this side. Only I can get answer. Osama. Osama has opened my previous presentation. So Osama has opened it. Uday has seen it.
I have another answer.
I can see that, Osama. What is happening?
I have another answer. Probably they prevent the patella.
No. Listen to Osama. Now, Osama, I want explanation how it is happening. Uday gave a similar answer, like you. You have some better answer?
No, not better. You want to explain it?
Yeah, you want me to, yeah, can you explain it?
Because you cannot inject from passing from the tendon. You have to pass from the muscle.
Really? You can so many places you pass from the tendon, no big deal.
The problem is the nerve.
What nerve? What nerve and artery is here? Hold on. Let him express himself. Yes, Mohammed.
The important thing whenever we think about
Tell me the nerve and artery. Tell me a nerve and artery. Who's here? You learn this thigh. It's completed.
Yes.
So which nerve and artery was explained here? They are in the front?
No, they're in the van.
So we are not talking posterior. This is not van. Anterior?
We're talking anterior. We're not talking
Here, do you have any artery and vein? I want the evidence. There is no. So here in the midline you have some artery and vein. You don't have aslan any artery and vein here. There is no artery and vein here. Great saphenous vein, my dear, goes somewhere here. Here, somewhere here. Great saphenous lives here.
What about the decent genicular?
It's not intramuscular. It's not intramuscular.
Intramuscular, my dear, why I put it here? I can put it on top, I can put it on side. I have the muscle right from the knee, right up to the hip. Why here? Why only stars here?
for the knee joint.
Under the muscle, there's a bursa.
So, you want to go to the bursa?
Yeah, we injection on the detail to create the bursa.
Bursa, why? If it's not bursitis, then what's the need? Why? How synovial fluid reach here? No. See now, how synovial fluid reach here? That's my question.
The suprapatellar bursa, it's synovial membrane continuous with the synovial membrane of the
Why? Give a big hand to him. Now, what he's trying to say, I'll come up with the conclusion. I'll show it to you. But they were trying. Tariq was on the track. He was on the track. But I will show you, Muhammad, what is happening. Najib, what is happening here. So this is the safe side which Osama read and explained to you. So now this is the posterior aspect of a knee joint. You can see a very definitive capsule. So now why this was happening, Muhammad? Because we said that anteriorly we don't have a proper capsule. That's why it was possible we are approaching higher up. How we are approaching higher up, I can show it to you in after 2-3 slides, not now. So you are looking at the posterior capsule, you are looking at the ligaments, and you are looking at the gastrocnemius muscle, you are looking at who is this muscle? Semimembranosus. You are looking at oblique popliteal ligament. So this is more. And you are looking at biceps. See that bicep femoris, it doesn't go straight to the fibula, it splits over the fibular collateral ligament, it overrides it. So this keeps on functioning. They are attached to the similar place, but because it overrides it, so there is a freedom for the free movement of this tendon, of this ligament in this place. Are you clear? Yes. Going further, this is my popliteus, which is going inside the joint capsule. Now what I'm doing, I'm bringing another arcuate popliteal ligament. So there are so many ligaments here. Now there is my popliteal artery. We all know popliteal artery is what? Abdominal aorta, L4, divides into common iliacs. Sacroiliac joints, external and internal iliac. Internal iliac goes to the pelvic organs. External iliac, coming down, passes under the inguinal ligament. Change its name to femoral. Runs in the femoral triangle. Gets into the adductor canal. Pierces the adductor magnus. Goes to the back. When it reaches to the back, we call it popliteal artery. It lives in the popliteal fossa. When it comes down near to this interosseous membrane, it becomes anterior tibial, which pierces this interosseous membrane, goes to the anterior compartment of the leg, and this continues as the posterior tibial artery in the posterior compartment of the leg. And then it continues down, anterior tibial artery will become dorsalis pedis artery. It ends in the first web space. Posterior tibial artery, it goes down, it gives a lateral branch, a fibular branch, and then it makes an plexus, it makes an arc, it makes an arch there. So we'll be learning that shortly. So is this clear so far? So now we have so many branches, like we learned anastomosis around the elbow. Here we have anastomosis around the knee, which Tariq was trying to bring one branch here. So there are so many branches. I'll be showing you only 4 and 5. Guys, the class who are now in third year, for them this was an SAQ question. Name the arteries contributing to the anastomosis around the knee joint. Ask them. And they were able to write 4 or 5, so they get 10 out of 0.5 out of 10. So there are very few mentioned here. GA stands for genicular artery. So now I have popliteal vein and I have the tributaries with the similar names. Just for reminder. My sciatic nerve bifurcates into common fibular and tibial nerve. Is it all clear? Now we are coming to the superior surface of the tibia. And now there is an articulating surface. Oh, this is not meniscus, my dear Muhammad. Meniscus is yet to come. This is the articulating surface. Lateral, and this is a medial. You can see that medial one is bigger because my medial condyle has more length to articulate and my lateral one has short length to articulate. So I'll put, now this is meniscus, C-shape cartilages, and they need to be fixed here, so I need to put these horns. They are fixing these menisci to the upper surface of the tibia, the condyle of the tibia. Is this clear? Now there is a capsule. There are some reinforcements. This is my medial patellar retinaculum. This is my patellar ligament. There I have tibial collateral ligament. There I have, who is this? Semimembranosus tendon. Who is this? Oblique popliteal. Who is this? No.
Popliteal muscle.
Fibular collateral. And there I have popliteus. That is inside. Remember, it went inside the capsule. And then I need to put a bursa here also. Bursa is coming. So you can see that they are blended and they are separate. Is this point clear? Now going further, there is my lateral patellar retinaculum. Iliotibial tract is there, that is reinforcing that. This is my posterior cruciate ligament. And there is my anterior cruciate ligament. Now these ligaments, these things, these cruciate ligaments and these menisci, they are within the joint. They are intracapsular, but they are not in the joint cavity. Why? I am putting synovial membrane here. Are they still in this?
No.
So they are not in the synovial membrane, but they are in the capsule. Got it? So establish to make out the difference. One MCQ can be generated very nicely. Which of the following ligaments are intracapsular? Or which of the following ligaments are in the joint space or in the synovial membrane? So you can be differentiated. And this is where you can be confused.
I'll say none of the above.
So, yes, very right. So this is the synovial fluid in the synovial membrane. And can you see any ligament inside? Nobody. All of them are outside. Now there are some pad of fats to improvise some packing. Is this clear? All of them are intra-articular, but they are not in the joint space. They are not in the synovial membrane. All of them are out. Meniscus are out, anterior posterior cruciates are out. But they are intra-articular. They are intra-articular but not in the synovial cavity. Synovial cavity have only synovial fluid. Intra-articular, you can put anterior posterior cruciate, you can put menisci. Right? Any question?
Yes.
What?
How is the menisci in extracapsular?
Who says extracapsular?
Extrasynovial.
No, who says extracapsular?
I'm sorry.
Huh.
Extrasynovial.
I will explain you in a side view. I cannot show you right now. Yes.
Yeah, I was just going to ask if the menisci...
Yeah. So now, what Muhammad want, let me bring it. Locking and unlocking we have talked about. So I'll not spend time on this. We know about this. Now, this is important. This is important. Why this is important? Because now I'll be establishing the rotational injury. This guy is skiing. How many of you did skiing ever?
Not me.
You involved in skiing. So this guy is coming, he's enjoying his skiing. He's coming with a great force from a top mountain and he was going fine, everything was best. Suddenly it was his bad day. This right foot stuck with a rock here. When he stuck with a rock here, now his foot got stuck and he is going in a momentum. He is going with inertia and his body weight is there and he is coming from a height. He was going with a speed but foot got stuck. He cannot do anything except for this foot is being rotated outwards. So there is an external rotation. So the next picture is this. Got it? So there is a rotation occurring at this right knee joint. Is that happening? So now there are forces. He is preventive. Something is being pressured. His body weight, inertia, everything is working. So there is more stress, there is a more twist across this joint. And this is affecting. There is a more opening, more external rotation. And the injury is more on the medial side. So now, let's take this person. Let's explore his knee joint. Let's draw him. And now we can see that there was an force, there was opposing forces, and there was stress on the medial side. We all agree with this?
Yes.
Now with this effect, the ligament tears, the damage occurs here. Whose damage? My tibial collateral ligament. With this damage, they are connected. My meniscus is also gone. So more severity. And story is not ending here. This is a rotational injury. The leg was extended. So I can anticipate ACL is also gone. MCL is gone, medial meniscus is gone, and ACL is gone. Now, this person, his next question is, doctor, what is the treatment? Tell me, does he need immediate surgery? Immediate surgery. Wait, stabilize him. explain to him. Then without surgery, nothing gonna help. Okay, you need to do surgery. Now his question is, doctor, after how long? It might gonna?
They need plates, I mean, for the ligament.
So now, his question is, I have my league after 2 months. I'm a finalist. Will I be able to go for my league? So now, on what basis you distinguish that? So there is a criteria. First see, after this injury, what is the outcome? We know that. So now on this image, this is a CT or MR. And what you see on that, because patient will never come to you with this picture. He will never come to you with this picture. He will come to you, you're going to see it only on MR. So MR will demonstrate, all forces are there. MR will be demonstrating an injury here to the MCL, injury to this meniscus, and injury to the ACL. This is MR finding. Now by seeing this report on an MR, now you can answer him. This injury to the meniscus is a bucket handle type of injury. Have you seen bucket? It has a handle. Handle falls on a side, arc shape. So now this helps you to understand. You can write in the notes, this person has injured his tibial collateral ligament, is visible ACL injury, and also visible there is an injury which has occurred to the medial meniscus and is a bucket handle type of injury. Now it's easy for you. On what criteria you can tell him you will be back to your normal sports activity after 6 months, or you may require more time. So to get into this answer, we know that after this injury, within this synovial membrane, because it's all ruptured here, so now there's a leakage of blood from the capillaries. Capillaries got damaged. So now blood is filling in this joint space, and that is called hemarthrosis. Blood in the joint space, blood in the synovial membrane. And it has ruptured has occurred, so blood is oozing out. Now, how I can answer him for his question when I am ready to play? So we know that these are the pictures. So now, can you see this dotted line? This is up till this dotted line is the vascular zone. The peripheral zone of his meniscus is vascular, and central zone is avascular. Why? This is the central zone. Central zone is avascular, peripheral zone is vascular. Why this is there? No. Answer my question.
Because the circumflex arteries are outside the cancer.
So they can come. So they can come even to this part. Yes, Tariq. So, anybody else? Anybody want to try?
The central portion is the most amount of pressure and go into oxygen the capillaries. So you put them on the area with this special.
Give a big hand to him. Why? Tariq was also right. Tariq needs to give more explanation. Guys, if we have arteries in the central part, the body weight is there. It can press the arteries. It can crush the arteries. So in the central zone, which is avascular, so synovial fluid, through diffusion, it sends nutrition to this zone. So there is a slow healing. And in the peripheral zone, because arteries can survive here and arteries cannot survive here. So for that reason, the peripheral zone becomes vascular, so the healing is early. Healing is better. Healing is fast. And in the central zone, healing is very low, is very weak, because the nutrition comes not through the blood supply, the nutrition comes through the diffusion process, and that is a slow process. Is this clear? So you can predict after looking at the site of injury. Is this clear?
You told us earlier that...
His question is, I said the menisci is not in the synovial membrane. They are outside the synovial membrane. So now, when there is a damage, who's that severe, it crush a cartilage. Synovial membrane is very thin.
Okay.
It's very thin. When this cartilage got a damage, so it breached the synovial membrane as well. this synovial membrane is damaged, now this blood which is leaking from this cartilage will come into the synovial membrane, the joint space inside, within the synovial membrane space. So blood starts coming. So now this is the limit of the synovial membrane, and blood starts filling within the synovial space because the membrane is very thin. So once there is a rupture across this menisci, the force is that strong which causes rupture of a cartilage. In front of it, a membrane is a very tiny thing. So the shearing forces are that strong that it causes significant damage over the synovial membrane. So now the oozing blood which is coming from the capillaries is filling the joint space. And this person will present to you with a swollen knee, with restricted movements, painful knee. And once you feel it, you can feel there's a fluid around. You put a needle in, you can aspirate blood. So that confirms hemarthrosis. Is this concept clear? Now we know it, how we can predict the process of healing and how we can give answer. Yes, my dear.
If you have ruptured, which part of the meniscus has longer healing?
The longer healing is the central zone, the better healing in the peripheral zone. Sometimes we need to take out the meniscus, because if there is too much damage and it interferes with the process, so we need to take it out. I will say it again. No, hemarthrosis is the process when blood is visible within the whole synovial space. So now,
so if in the case of hemarthrosis, do we lose the synovial fluid? Does it seep?
Obviously, everything is now mixing up, synovial fluid, the joint has limitation of the movements, it's all swollen, patient is in pain, and you are preparing, you are waiting for surgery. You are waiting for surgery. You have explained to the person, you have explained to the family, patient is looking for who is the best doctor in the town, and he will be going to that doctor. He is looking for his money, he is looking for his insurance, he will be looking for his logistic, what is a suitable time for him, so he will definitely going for a surgery. But now synovial fluid is mixed with the blood. So there are consequences, there is a pain, if he is involved in an active type of work, he has to be restricted, he may go on a crutches, and there so many other additional modifications are occurring. Okay. So now, these two slides, I don't think you need to go for them because it's more than your level. I don't want to go for the patellar forces and all that. Now, coming to this is an important slide, and that will explain the mechanism, what you guys have started, why we are putting stars on that muscle. So now what you are looking at, these structures we are familiar with. We know about posteriorly we have a very good capsule. Laterally we have a very good capsule. Anteriorly we don't need a capsule because this space is being covered by those reticuli. So now you can see that synovial membrane lines it. And you can see that synovial membrane comes here. Now the synovial membrane, it fills upon. It pops up. So now my question is, why this synovial membrane is going on top? It acts as a bursa, but who pulls it upwards? What muscle? Osama, don't see the previous slide. Quadriceps tendon? Who? No. No. Yeah. Yeah, very close. Very good. Give a big hand. So, there is a small muscle here, its name is articular genu, that pulls this synovial membrane. Now, if we go back to our discussion, we put a syringe here. Let's bring a syringe here. So now you put a needle here. You are injecting in the joint space. You are injecting in the joint space because it's all connected. Synovial fluid is same here. So no need to get into the joint space. You can inject into the joint space if you inject through these vasti muscle because it's connected the synovial membrane is the same which is here. So any injection in this side, you can put the injection thing is here.
Local
Now,
anesthetic?
local anesthetic and painkiller. So that will give pain relief.
Ah,
That is
for that damage.
no, not for that damage. Some people have chronic pain in their knees.
For,
Chronic pain. Some older people have joint pains. Have you seen them? So you need to give joint injection. So this is the place, safest place, because if you put your needle here, you may damage the meniscus. You may cause a trauma to the meniscus. You may cause a trauma to the cruciate. You may cause a trauma to the collateral muscles. But here if you inject, you are going through the vastus. So that's why this makes it a safe site for that. Now let's talk of the bursas. So there is a bursa in front of the patella. What name you suggest?
Patellar bursa?
Pre-patellar bursa. So now this below the patella. Infrapatellar? No. Okay, if I take Tariq word, Tariq is saying post-patellar, that has to come here.
Yes.
And that is not possible. Infra. But this is, yeah, you are right, Muhammad. But we have two categories. This is a deep, this is a superficial. So they are together infrapatellar bursa. Okay? So you have pre-patellar. There are lateral bursas, anterior bursas. There are so many. But I'm showing you someone who are important. Now what happens? There is a herniation. Herniation of the synovial membrane through the capsule into the popliteal fossa. And now this herniation, it affects some of the people. And this herniation of the synovial membrane into the popliteal fossa, it has a name to it. And that is called as popliteal cyst, if that condition occurs, or Baker cyst. I'm sure this has to do nothing with the bakery. It has to do nothing with Makhabis. It has to do something with Mr. Baker.
Well, with the baker itself.
Yeah. So is the popliteal cyst or Baker cyst? And you know, if someone have it, this person will have problem with flexion occurring at knee. Because there's an extra mass which is present under the skin, and that will cause some disturbance. It might cause pressure effect over the nerve. It might cause there's a mass here there. So now the synovial fluid is popping out here. So this is the thing detail about the popliteal cyst, and this is this bursitis. If you have inflammation of the bursa, now what is this?
A knee joint.
Arthroscopy, a knee joint, but you are in the knee joint.
And this is the anterior cruciate ligament.
So you can see that it was attached here. This is the medial wall of the lateral condyle, and this is being separated from here. Now there is an instrument by which you can suture here, you can replace here, you can put some graft here. So this procedure is called arthroscopy. You are within the joint space, and you are looking at the synovial membrane which lines everything.
And this is hemarthritis.
Yeah, if there is more blood, because right now you cannot see the blood, because when we do this procedure, we have a fast infusion of fluid. So fluid has been, that's why it's been visible, otherwise this cavity is a collapsed cavity. Once we put our arthroscope is not bigger than a small size pencil. It's a very thin instrument. It's, maybe 4 mm or 6 mm thickness. You just insert inside, it has a camera, it has a vision thing, then you put another instrument and you can nibble, you can sew, you can do all what you need, you can put reinforcement, so you can repair. So arthroscopy make it very easy for diagnosis, and it made it very easy for aspiration, made it very easy for looking for if there is any cancer, any growth occurring within this space, you can diagnose it, and you can also suture it, bring it to its place, or if you want to put a graft, you can reinforce the graft by doing this arthroscopic thing. So there is no chance, no need to open up the whole joint. You open up the joint, the healing is poor, the healing time is more required, so there is a less time required. So this is the arthroscopic examination, which reveals you the injury to the anterior cruciate ligament. Wait, sabr.
Why is that yellow thing on the left?
This?
Yeah.
No, my dear. This is after trauma. This is after trauma. There is an injury occurring here. So there are the broken fibers. So you don't know what it is. Exactly you have to, but this is nothing significant. This is a synovial membrane which has been popped up. There is a tear, there is some leakage, there is some fluid entering there. So you shouldn't be bothered for. Look at the clarity of the field. You look at how nicely shining the synovial membrane. and you are in the joint space, and this is where you can see the broken the ligament, and you have the objective is to just to connect this broken part to its original place. Right now, guys, what do you think? What is going wrong here?
So many things.
So many things. Yes, Rafe. Can you come on the board? Rafe is saying there's a fracture here. You agree to him?
Yes.
What else? Tariq.
There's a varus.
Come on. Before varus and valgus, there are so many obvious things. Guys, have you ever seen? Yes. Khali Wali. Have you seen before? We will learn that the upper surface of the tibia, upper condyle of tibia was flat. Why this depression is here?
Compression.
So now see what happens. There is a big pressure. This fragment is broken from here. It is being pushed downwards. By this push, this whole fragment is being detached from the main bone. See, jump too much, huh?
From a mountain. From a second.
Yeah. Now what's wrong here?
The popliteus muscle did not do its job, so it did not.
So then you need to take an X-ray.
That's why.
You need to take an X-ray for that? No need.
But it's rotated.
Guys, it's normal.
Normal.
Yeah. What's here? What's here? Fracture here?
La.
Here?
Yes, right.
There are more findings, but if you pick this fracture, perfect. The other findings are, there you can see the blood, there is a fatty pad, but if you don't do it, fine. Patella is perfectly alright. So this is the finding, but this, if you know this much, enough for you. No, that is a broken thing, you cannot predict. Now what's wrong here? Dislocation. Look at where are the condyles and where is the condyle of tibia. So everything is apart. It's twisted. Someone said this word. Now what's wrong?
The plateau is broken.
Plateau is broken here. Mohammed, actually I know you are close to the answer. You don't know the exact name for that place. Plateau is not broken. The eminence is broken. So this is an avulsion type of fracture. But fine, you are close. So it's mentioned here what is wrong. You can see that. Now, my question is, with this fracture, patient present with a wrist drop, which nerve is affected? Not wrist drop, foot drop, sorry.
Common fibular nerve.
Foot drop, Habibi. You have fibula in your hand? I said wrong, yeah.
Common fibular.
No, you said tibial nerve, I said no, left with the common. Guys, common fibular nerve is the one who brings dorsiflexion. Plantar flexion is biotibial nerve. So it brings dorsiflexion. So if common fibular, because the common fibular goes very close to the neck of fibula. If that is damaged, patient is unable to bring dorsiflexion. So dorsiflexion is not there, so foot is like this always. So that's called foot drop. You learned the wrist drop, now you're learning today the foot drop. Is that clear? Now what is this? What is this? Obviously this is a prosthesis, but why? What is this? An exact example of total knee replacement.
Yes.
Total knee replacement when the condyles of the femur and the condyle of the tibia are destroyed due to aging, due to some other factors, due to some osteoporosis and all that. These knee people need to be replacements. And these replacements are, the knee has to be replaced. So don't think we bring a cow knee and put it in human. It's not happening. We just bring these prostheses, we just make the space, we fix them here and we leave it, and patient goes to the best quality of life. I know someone very close to me, she was not able to walk. If she was asked to walk from this chair to that table, she usually take 30 to 40 minutes for this much walk. she was taken for a surgery, for both knees were replaced. After the replacement of her both knees, in the same year, she went to perform Hajj on her own. So, I saw like in very close of my family, the improvement, and it's worldwide, and it's giving a very nice results, and people have the best quality of life. Those who always need a wheelchair, if you take them for the knee replacements, there are always a success story.
Is there a difference between efficiency and normal knee?
Obviously, the natural is natural, the artificial is artificial. These people, they cannot sit now on the floor. They cannot sit on the floor. If they try to do so, this can be damaged. But you know, what's the big deal? If you don't sit on the floor, who cares? You could sit on a chair. Only a little bit lifestyle, but you know, you have freedom. You can walk. Before you need a wheelchair. Now you can walk. You can do Umrah.
It's still the same shape as the other ones, so shouldn't it have the same range of motion?
Perfect. Everything is there, but you cannot sit in a classic sitting position. We fix it. There's a technique. There's a process. Now, yesterday you learned these. Hassan Sheba was explaining these. Anterior draw test. So you are checking for ACL, and posterior draw test you are checking for PCL. Is that right? Any further question? Anything which bothers you? So now I'll go for the attendance part.